Hello, thanks for coming back and joining the next section. My name is Leah Morris, and I've had the opportunity and privilege to be on the PCARE Planning Committee this year. Thank you, Jay and Dr. Tran. Also want to do a shout out to Shari, who has been doing many of the logistics for this conference, which really has been wonderful, and she's done a lot of work. Today we're going to have an hour and a half together with the next two speakers, Liz Salmi and Dr. Michael Fratkin. And they, as part of my work on the planning committee, I had the opportunity to work with my friends, Michael and Liz, to think about this session and sort of how they wanted to set it up. And part of what they said they wanted to do was engage with the audience and have a conversation. And so Liz and Michael will each speak a little bit about ideas and information they'd like to share, and then we'll have a bit of a conversation that I'll be able to help moderate and engage the audience with you all. On this front, they asked me to share a little bit about sort of how I know them and a little bit about the work that I'm doing now. And so with that, I wanted to just describe some of the work that I've had the opportunity to start working on in the past few months. With a colleague, Dr. Nathan Fairman, we co-direct the Supportive Oncology Services program here at UC Davis at the Cancer Center. And I feel really privileged because you saw the video about Dr. Marlene, and she actually was the founder of the Supportive Oncology Services program some years ago. And so I feel like we've picked up the legacy that Dr. Marlene started and really are happy to continue on with that work. The Supportive Oncology Services is really aligned with palliative care because we also provide a layer of support to people who are in active treatment for their cancer. Under the Supportive Oncology team, we have the responsibility for our newly opened palliative care clinic. Dr. Muklan and Megan are here in the audience who staff that clinic. We also have an oncology pain clinic. We have a psycho-oncology clinic. We get to work with all kinds of issues around families and help support them as they're adjusting and dealing with a life-challenging diagnosis of cancer. The team consists of nurses, nurse navigators, case managers, dietitians, social workers, physicians, obviously, and community education folks. So we're really trying to pull together a host of services and a really strong team to make sure we support the patients at the Cancer Center who are dealing with their oncology diagnosis. A little bit of my story and how I got to know Liz and Michael. Before this, I had the opportunity to work with Liz at the Coalition for Compassionate Care. Some of you all here know that organization, a sort of policy organization that works really hard to advance the world's understanding, the California understanding of palliative care. Liz and I got to work on some conference activities and some publications related to advancing palliative care understanding in the broader audience. And so that was a lot of fun to work with Liz. I got to work with Michael because at that time I was nurse practitioner and director of policy at YOLO Hospice and YOLO Care Palliative Program. They're also here in the audience. And Michael invited us to write a grant together, and we were very fortunate to get funded by the California Healthcare Foundation, so I got to work with his team to look at how to advance rural palliative care programs. And we had a lot of fun and learned a lot about how we learn in the rural areas and how do we start to develop networks and work with other colleagues to advance this wonderful world of palliative care. So those are a little bit about how we know each other. I want to tell you a little bit about Liz and a little bit about Michael. Some of these are their words and some I added to it. So Liz Salmi is a former punk rock drummer, turned communication expert, I believed, turned cancer patient and survivor, I will add, and palliative care advocate. Liz now works for a Harvard Medical School teaching hospital on a research project called Open Notes. After being diagnosed with a life-limiting condition at 29 years old, she immediately put her digital communication skills into action by blogging, chronicling her daily symptoms, and seeing what trouble she could get into with her online medical information. Anybody know that sort of thing? Today, Liz is passionate about empowering regular people to be more engaged in their own health care and to improve their experience as patients. In addition to her Open Notes work, Liz leads stakeholder engagement efforts for a palliative neuro-oncology research network, which was established by the Patient-Centered Outcomes Research Institute, PCARE, and her interests include clinical informatics, citizen science, and human-centered design. Dr. Michael Fratkin, again his words, a former ski bum, rock climber, a deadhead, Humboldt County resident, turned builder, innovator, and dreamer. Michael founded Resolution Care, and this comes from the website, for bringing capable and compassionate care to everyone, everywhere, in the face of serious illness. While Michael has been noted in publications such as Forbes or the Washington Post, I think he's grounded in the notion that he works with a group of healthcare providers that understand that people are not malfunctioning machines or exploitable consumers or anything less. He says that our living and dying is not medical. Resolution Care was built on the strength of good sense, a recognition that the economics of providing healthcare to those with serious illness is changing fast. More is not better. Providing healthcare should be driven by the value of it to the people, defined by satisfaction with the experience and their well-being, rather than number of encounters. For Michael, it's personal. From his words, I let them know who I am and explore who they are. I help them understand the totality of their circumstances. I identify with them what's important to them and what matters to them, given all the things that can't be changed or can't be known about their future course. Then I roll up my sleeves and let them tell me what my job is. I'm gonna welcome Liz and Michael. We'll start with Liz.
Can you hear me? Am I louder than Leah? Fantastic. All right. I'm so excited to be here. It's really an honor to be invited to present in front of you all today. Let's make sure these slides work. It looks like it got hit. There we go. Michael and I share the first two slides. We have nothing fancy to disclose other than some grant funding. So I'm a patient. Leah already spoiler alerted that. I'm also a baby researcher. We're going to learn a little bit more about that later. And I want to note that I have a professional background in healthcare for maybe the past 5 years, but my original background is in digital communications. But as I tell this story, it's virtually impossible for me to separate my patient experience to now my healthcare communications experience, now my baby researcher experience. It's all in one. So as you hear this story, it's going to come out that way. I tried to make it fancy and separate everything and sound all academic, but there's no way I can do it. And it's hard to figure out how I will present this. So today I'm going to tell you a story that's about culture change and how that pertains to palliative care. I believe that all patients are researchers. Bear with me. The state of patienthood has changed so much over the last 10 to 12 to 15 years. People have greater access to information, for better or worse. People are curious, and we're now starting to play with our healthcare information, for better or worse, I think for better. And I think patients and care partners are turning into researchers. Does anyone know Shirley Otis Green? She's this, oh my gosh, everybody. So for those of you who don't, the other half of the room, Shirley Otis Green is this amazing palliative care social worker. She's actually written books on palliative care social work. And I'm lucky enough that she's a mentor to me. And she says there's two kinds of research. There's research with a big R, like NIH-funded stuff, and then there's research with a little r. And I think our patients, people like me, are doing research, little r. You'll learn more about that in a second. And the future of medical research will be done in partnership with patients. Now, not everyone in this room is a researcher, but it's something to think about, pay attention. So to tell you this story, I need to start with my beginnings. So I'm going to take you all the way back to the year 2005. Who remembers 2005? In 2005, I was age 25, and I got my first real job. And along with this real job, I got to pick a health plan. And out of the options presented to me, I picked Kaiser Permanente for one really important reason. I liked their website. According to this website, I could pick a doctor, make appointments, and order prescription refills all online. And this was awesome because it meant I did not need to speak to anyone. 3 years later, in 2008, 1 week after my 29th birthday, I suffered a massive seizure. I landed in the ER, and a scan showed I had a mass in my brain. And then after a 9-hour surgery, I learned I have an astrocytoma, which is a slow-growing but malignant brain tumor with a high rate of recurrence. 6 months later, the tumor grew back. And then that sent me into a whirlwind of treatments over the next 2 years, including a second brain surgery, continued struggles with seizures, physical and occupational therapy, and then 24 months of chemotherapy. There is no right way to respond to a cancer diagnosis. But my way was to respond with curiosity. And because I have a digital communications background, my instinctual response was to start blogging about this experience and translating everything I was going through to a lay audience of my family and my friends. And in case the blog doesn't make it obvious, I am a big nerd. And so within a few weeks after the diagnosis, I became an expert on the Kaiser online patient portal. After every appointment or test, I would log into that portal and look up labs and results depicting various details about what was going on in my body. And it was really cool. And if there's a word or a phrase I didn't know, I would go online to look it up. And if I couldn't find what I was looking for, I would use the same portal to send my doctor a message to ask questions. Because what use is this kind of information without interpretation? It went on like this until treatment ended in April 2011. And my care is still handled like this today, even though I'm now a patient at both UCSF and UC Davis. However, today in 2019, we actually have more information in our patient portals. In addition to lab results, we can often see radiology reports. About less than 10% of the US population can actually read our doctor's notes through these portals, which is kind of cool. But outside of our patient portals, so much else has changed in the last 10 to 15 years. So when in 2005, I picked a health plan based on the promise to be more digitally connected, even more stuff happened. In 2006, the internet hit 1 billion users worldwide. In early 2007, Apple introduced the iPhone, which became the world's best media player, world's best phone, world's best way to get to the web. And then a whole bunch of companies emerged around this time, and it transformed the way we collaborate, communicate, create, and gain access to information throughout every aspect of our lives. Why does this stuff matter? 1 year later, in 2008, I became a patient. So my whole healthcare experience has been colored and shaped by a new culture of easy access to information. The patient experience has changed over the last 10, 15 years. It is changing now, and it has changed. This week, on my phone, I was able to look up my sleep patterns being tracked by my Fitbit. I logged into my patient portal and through my phone read the last radiology report from my brain MRI. And Apple Health Records is now merging the disparate health data from UC Davis and UCSF into one personal health record. Is everyone doing this? No, but it is very possible. Regular people have the tools to be researchers on themselves. And they are already doing so by conducting experiments with their health. And I do not mean research, big R, per Shirley Otis Green. I mean research, little r. And what does little r look like? These are the questions. All good research is based on a good question. What are we trying to figure out? And people are saying, well, how many extra steps does it take each day to lose a pound? How does a change in diet improve my mood or fatigue? If I walk for 20 minutes, will that improve my recovery after this surgery? How we connect with the world has changed, and how we connect with others about our health has changed. I am a member of a private Facebook group for people living with brain tumors and brain cancers. And this is just one question posed to this group. It's pretty amazing. Person asks, can anyone talk to me about their effects from taking phenobarbital? Can any of you answer a patient's question about what it feels like to take phenobarbital? Hopefully I'm saying that correctly because I take Keppra. Okay, so, but can any of you, can you say you know what it feels like? Probably not. Some of you might. You don't have to raise your hand. But can you answer that question from a first-person point of view? I believe feel free to debate me on this, but that patients like me are being created every day. Many of you might be thinking, I haven't seen any of this. Not my patients. My patients are too sick to be doing wild stuff like this. But I'm telling you, your future patients, if not today, but your future patients are me. We talk about generations of people. The boomers, Gen X, millennials. I think we're seeing a new generation of patients. The people who entered the system in the last 10 years, AKA me, and we have grown up with this new culture, and we respond to healthcare in a different way, or engaged in a different way, or have the ability to contribute and participate in a new way. In fact, today, out of the 40,000 Google searches made every second, 2,000 of these searches every second are health-related. People are interested and curious. But is there a similar culture change on the medicine side, on the healthcare side? People often say medicine, healthcare, so slow to adapt. That's true. But I think we're seeing this slow culture change happening on the other side. The other side, we're our side. My side, your side, I don't know. Again, two hats. Here are two examples. A major academic medical journal has recently created, actually in the last 2 years, a patient-public partnership. If you want to publish in the British Medical Journal or the BMJ, as an author, you're required to document how you involved patients or the public in your paper, whether that's research, opinion, whatever. They also have a patient review panel. I'm part of this panel. I guess that's a disclosure. So if anyone's writing a paper about glioblastoma or palliative care as a person who's had lived experience in this space, I review your paper. And then they request that all of the authors co-produce their paper in some way with patients. Few papers are published with patient partnership at this point, but they want to grow that. So that's one example. Another example, who's heard of the Patient-Centered Outcomes Research Institute, or PCARE? Okay, if you do research, you're looking for money to do research, PCARE is a place with some money. They fund comparative effectiveness research, so comparing two interventions to see whatever. And they request that all research being done with their money must be meaningful to patients. What does that mean? It means if you're a researcher doing stuff in glioblastoma, that you don't just say, hey, I want to research what I think is important, that you go to patients and care partners, their family members, and research what's important to them. Kind of cool, right? They want patients to be included in the design of the research. And then at the end, once all the research is done, patient reviewers review that research to say, was this helpful? Should we fund them again? Interesting. What does any of this have to do with palliative care? I'm getting there, but I have to take you back again into my life. So as a person now living with a brain tumor, a malignant brain tumor for over 10 years, I have so many friends with brain tumors and brain cancer. This is just a whole bunch of selfies from like one day of hanging out. I have so many other pictures of hanging out with my friends with brain tumors. But the problem is if you have friends with brain tumors and brain cancers, I lose a friend every month. A friend dies. And some of these friends are really close to me. So about at least one friend a year that's super close to me dies. And we often talk in this palliative care space about the concept of a good death, and then there are bad deaths. And I don't know how many of you have ever cared for someone with glioblastoma, but it can get a little hanky there at the end. And not every patient or family member is prepared for the side effects that happen along the way and the end of life. About 7 years after my own diagnosis, my dad was diagnosed with glioblastoma, and he died about 7 months later. I know, what are the odds? That's like a whole other talk. So we'll deal with that later. I knew so much about how the disease works that I made sure he got access to palliative care early on. And then when there was nothing left to do, we got him into hospice early, and he had a really great experience. If any family could do brain cancer right, it was mine. But I don't think you should have to be an expert to get the right care at the right time. So, I mentioned PCARE, the Patient-Centered Outcomes Research Institute, the organization that is interested in funding research that is meaningful to patients, looking at stuff that's interesting to patients. Well, because I'm one of the reviewers, of, the nerd patients who review some of the research, I'm on their email list. And if you're on an email list, you get all these updates about what's going on. And I got an update about a new funding mechanism they were putting out called the Pipeline to Proposal Award. PCARE realized that researchers didn't know how to interact with patients and care partners. How do you involve patients and care partners in research? They hadn't cracked the nut. As a reviewer, I looked at a paper about a research project where the researchers said, yes, we totally involved patients and care partners. They designed the logo for our project. I was like, that was not meaningful inclusion of patients. So Pipeline to Proposal as a funding mechanism was the concept of build a group of stakeholders first. Researchers, clinicians, and patients and care partners all impacted by the same thing and design a research question together. It was pre-research. And the email said, we're looking at funding more pre-research on rare diseases to build that stakeholder group and identify a research priority. And I looked at that email and I was like, ooh, brain tumors, all of them together are a rare disease, less than 200,000 diagnoses each year, but specifically glioblastoma, which is really deadly. I have all these friends impacted, my family, including maybe me one day, rare disease. And I thought, well, what would I want to look at? Palliative care. Any of you are familiar with what is colloquially known as the Temmel study? Okay, 3 people. Let me explain. In the early 2000s, a paper was published by Jennifer Temmel et al., known as now the Temmel study, where they looked at early palliative care for patients with metastatic non-small cell lung cancer. And in this study, which was really groundbreaking, it showed that patients assigned to early palliative care had a better quality of life. Who here is like, yeah, duh, I knew that, okay? And then what was interesting about the paper, and maybe this is not replicable in other cancers, but it said, the median survival for those folks who received early palliative care was longer among patients who received regular standard of care. Now, if there was a drug out there that said, if you took drug X and you could live 1 month longer, everybody would be buying this. But you can't really patent palliative care, can you? So I was familiar with this study, and I thought, where in the brain cancer space, where in the glioblastoma space, where is our Temmel study? I would love to see that. So here I am, a patient living in the rare disease space who was really interested in a particular research topic. And I thought, let's challenge PCARE. Everyone who's being funded with this award mechanism are MDs and PhDs, but they say patient voices are so important. What if I, as a patient, applied for this funding? Would they give it to me? Well, there are challenges. Even though I had been working in the healthcare communication space, I am not a researcher. I am not familiar at all with research methods. I don't know how to design a budget for research. Is anyone going to take me seriously if I apply for this money? Well, you can't do anything alone. And as luck would have it, I actually met this amazing person, Dr. Bethany Kwan, who's a researcher at the University of Colorado. And I met her and her mother when I met her, 2 weeks before I met her, her mother had just died from glioblastoma and actually had a horrible end-of-life experience. And even though Bethany's mom was an OB-GYN, her dad was a neurologist, and she herself was a health sciences researcher, they couldn't do it right. They didn't do brain cancer right. So we decided to team up. And she was also interested in looking at palliative care and glioblastoma. And she was looking at the same award mechanism, this pipeline to proposals thing, but her challenges were, she didn't know anyone with expertise in brain cancer, and she didn't know anyone in palliative care. And she didn't have connections with people who might be the stakeholders in developing that research question. So if you took everything under what Bethany didn't know and put it under me, I knew those things. And if you took everything I didn't know, Bethany knew those things. By the way, you should follow Bethany on Twitter. She's awesome. So the question was, how do we apply for this award? If she applies under University of Colorado, they're going to take a ton of money out of this little budget of funds. If any of you work in research, you know, like the main academic organization will take 12% off the top. Or do I apply, but I don't have any way to pay the bills. I'm not a business. What do we do? We decided for fun to see if PCARE, the funder, would allow it. We decided to apply as me, and then we were awarded the funding. So spoiler alert, you probably saw this coming. We were awarded some funds. And I could talk for another like 40 minutes about the detailed play-by-play of everything we have done over the last year on this project. That's really fun, but I'm gonna just kind of cut to the highlights. Well, if you know, glioblastoma, horrible disease, everyone diagnosed today. 5 years from now, 95% of them will no longer be alive. Most people die within the first 17 months after diagnosis. Over the last 30 years, only 4 approved therapies have been created to treat this disease. And sadly, patients are not routinely referred to palliative care. And most folks only spend a few days on hospice. If you know there's a disease that's so brutal, like glioblastoma, and they're not routinely referred to palliative care like soon after diagnosis, like why is that happening? Okay, I'm kind of getting off track. Okay, so glioblastoma is a problem. So we build this group of rock star stakeholders. I say rock stars a lot. Of people, patients, I'm one of them, care partners, so people caring for people with glioblastoma, and then a mix of clinicians and researchers, neuro-oncologists, neuro-oncology neuroscientists, palliative care physician, palliative care social worker, Shirley Otis Green, research coordinators or representative from the SUREs, like this really diverse group to tackle this problem, to create a research question. I know that sounds ambiguous. And then some of these people are twofers. So they work in the clinical side, but then they also have a personal connection to glioblastoma. I'm going to compare for you the average PCARE-funded pipeline to proposal team and our team. Okay, this is where I'm showing off. So the pipeline, most other, our peers, there are 50 projects funded during this, with this particular award mechanism. Most other folks, they did their stakeholder recruitment and they identified a research priority in 12 months. Our group did full stakeholder recruitment, this picture back here, in 2 weeks, because we knew people, 16 of us. We did ethnographic interviews where we actually interviewed other patients and care partners that weren't the 16 of us. We interviewed a whole bunch of neuro-oncologists who were like, palliative care, we met regularly. We did an in-person design thinking meeting. We identified 3 top research priorities. Then we brought those 3 research priorities to a larger group of patients and clinicians and neuro-oncologists through online tweet chats, talk about that forever. We got to talk to a whole bunch of great organizations like the Palliative Care Research Cooperative Group, who's like, we're excited you're doing this. We talked to Jennifer Temmel, the lead author on that paper I cited earlier. Then we did presentations to other groups to say, we're working on this. Who wants to join us? We even got the nerve to call up like the NIH Center for Neurological Diseases and Disorders and said, we want to tell you about what we're doing. They said, that's great. But it was fun for them to know who we were. We identified a top research priority, and we even found 2 principal investigators who were like, yeah, we want to do that. That's awesome. We have 2 posters who are presenting in 2 months at the Society for Behavioral Medicine, which will turn into 2 papers, which will give us more street cred so we can do more research, and on and on. This is what happens when you bring together patients and care partners to bring these connections together, to have the gall and the nerve to say, let's talk to that researcher, let's call the NIH, and because we don't know any better, we're not afraid and our careers are not on the line. So at the end of the day, what we learned is there is no significant research, i.e. no research around palliative care and glioblastoma, none at all. There should be. So in the next 2 years of this project, and by the way, we're called the Brain Cancer Quality of Life Collaborative. We have to have a name. We're building a palliative and neuro-oncology research network. Oh my God. What's kind of wild about this is we're connecting neurologists to palliative care, and they usually don't talk to each other, but there is a growing neuro-pal community, and we're part of it now. We're building a network of sites. We're going to be doing palliative care pilots. If you're interested, we can talk about that. And then they're going to share their data, and one day we're going to have a big randomized controlled trial, and it'll be amazing. Okay, so some of you, so I'm closing on that and bringing things back to a larger stuff as I close. Some people want to know, how do you meet cool patients like me? What if you want to do research or engage more? That's something Leah's wondering. Go to a cool conference. Go outside of palliative care and go to other conferences that invite patients to present. Some of these are the Stanford Medicine X conference that's coming up in September, and other groups. PCARE has an annual conference. Twitter is a space. If you're not on Twitter, patients are there, clinicians are there, and they're connecting. And then some organizations, hospitals and health systems have patient family advisory councils. If you don't have one, you could, and just Google patient family advisory, how do I set one up? And then you can learn how to do it. I want to leave you with these tips. Even if you're not working in research, but you want to listen more to what your patients are up to and encourage their curiosity, these are my how you know your patient is a researcher. You know your patient is a researcher when they look up symptoms online. When patients bring information to the clinical visit. Your patients are researchers when they research a word or phrase, because they don't know it. Patients are researchers when they conduct a small R experiment. When they express interest in labs, imaging, and tests, ask for their medical records and their notes, ask you how things work, and they ask for a second opinion. Those are all good things. I'm leaving you with a photo I took by mistake. How many of you have ever looked at your photo roll later and you're like, when did I take this picture? I was putting it at the ground. Well, this is a happy accident. Almost 1 year ago today, we had our first ever in-person meeting for the Brain Cancer Quality of Life Collaborative. We brought all of our really cool stakeholder rock stars together in one place. It was here in Sacramento. And we had people from Washington, Arizona, California, Colorado, and Indiana. That's where all of our folks hailed from. We came here in Sacramento, and we had this amazing meeting, all these different minds, and I encouraged people to dress casually. I didn't want business suits, and I just wanted to break down all the barriers. There was no Dr. So-and-so. We all went by first names. That was the important thing. And I took this picture during the meeting, and if you can't tell from this photo, there is the feet of 4 people. One person is wearing sneakers, one person's kind of sitting on their legs, another person has ballet flats, and there's someone standing in their socks. Got comfortable there that day. These feet belong to a nurse manager from the UC San Francisco neuro-oncology program, a palliative care physician, a young man living with glioblastoma, and a woman caring for her father with glioblastoma. All of these people are experts in their experience, and they deserve to have a voice in the design of research impacting their professions and the care that they provide, and they're experts, more importantly, in their lives. So look out for your patient researchers. Think of ways you might start collaborating with them more in palliative care. And thanks for your time today. Yeah, I'm
Check.
doing it. Give me a second.
I think I might be wearing those same socks. Actually. Right? So, I fell in love with Liz when she was working at the Coalition. I don't know exactly. Friend love. Right. With a lowercase L. Lowercase L. I'm glad on the webcast, my wife and daughter are watching, I think. So, you got that? And to all you people out there on the webcast, thank you for joining us. The other thing that I realized as I was preparing for this talk is how little of what I know or share or communicate is original. I, like you, am derivative and so fortunate. One of my superhero powers is how hungry and curious I am about the value, wisdom, and magic of other people. And so I steal stuff all the time from people that I like. And so this hairstyle, I also stole from Liz, who has now moved on. Right? Yeah, there it is. She's moved on to something else, and maybe I'll do that. I might steal Bella's bangs. She just got my daughter. And Though I always refer to Steve Franey, my partner, as the suit and tie of resolution care. I haven't really gone for the whole suit, but I did wear a tie today. But I didn't tuck in my shirt. There it is. So I just want to share an experience with you in just about the same way I had that experience. I had a text with a little video clip in it. And just imagine, you're going through your day as a physician or a provider, a clinician, or whatever you are, and you get this video. Can you do it? Or I can do it. How do I do it? There we go, like that. This is our future, right? This is our future. The beautiful thing about this category of people called millennials is that they can't help but look straight at their lives and call it for what it is, shine light upon it, and whatever complaints we might have while we're wandering around on our front lawn telling people to get off of it. This is our future, right? So before I talk any further, I'll just also tell you something that while I believe in the word patient and its use in shorthand and communication and designation and distinction, for purposes of communication, I don't believe there is such a thing as a patient at all. There is no such thing as a patient. We are just a bunch of silly monkeys wandering around in our lives, trying to make sense of it, trying to connect to each other, trying to make or project meaning onto it. There are no patients. There are no doctors. So just want to make that clear. So let's see. So we had the talk, and I'm not going to belabor it, but it was beautiful. And we did it in 2 sets, and we did it using a video conferencing platform. And the folks involved, that's Charlie, who's now a social work student at the University of Washington. That's Adam, who is an extraordinary father of 3, philosopher, and kind of one of the most potent intellects that I've run into over these years. And that's Liz with not quite her most pointiest hairstyle, but one of her pointiest hairstyles. But given the point that we are just people having experiences, I'm going to share this little walk through how I arrived at this point. But I want to do it through the eyes of the people we care for. And I'll read that for you if I can. To envision and create a sustainable future, the infrastructure we build to care for people who care for people with serious illnesses must be centered on what people need. The blueprints must be drawn from the bedside outward, not from the institutions inward. We don't know what people need until we join them and explore with them what they need. We don't know better. Our institutions suck at meeting the needs of sick people, and they suck almost as bad at meeting our needs. The institutions we've built were not built to ensure that people with illness or people that care for people with illness have their needs met. They, like many institutions, even political ones, were built on the basis of economic forces, social and domination forces in the context of hundreds of years of oppressive patriarchy and all the rest of it. They are just a reflection of everything that lives in the rearview mirror. And we are not going to be able to build a future with the engineered structures of the status quo. We will be able to build a future with the raw materials of the way things are, and the way you are, and the way I am. But it's not going to look like it looks in the rearview mirror. Right? That's a big deal. That is a big deal. We go through our lives and we do our jobs and we assert our and contribute or accumulate our credentials. And we think that's what's going to get us to building the future that we all know we need. And it won't. Moment by moment, square by square, the patterns we weave are not easily seen while squinting at the tip of the needle. A last step back to see reveals the imperfect details and the perfect whole. We uniquely enjoy the privilege of perspective. We hang out in our work right at the edge of existence and non-existence with people. We get the opportunity, and I think that's probably what brings us great passion. We get the opportunity to see what really, really does matter for the people we care for. And we have the opportunity, if we can integrate it into our own lives, to lean more into the things that matter to us and away from the crazy social primate behavior that is not contributing to the well-being of our world. So I'm going to actually, David's piece was really useful, but I'm just going to say that I actually conflate soul and spirit. I like soul because it is more uniformly we're more used to it. Spirit has so much stuff to it. I'm comfortable with the word, but a lot of people, it has other meanings. But soul food, soul music, the soul of experiences, the soul of us is really the essence of us, the artistic or aesthetic reach of who we are. And so there's soul in everything that we do. There's soul in the spreadsheets that Steve Frady uses to describe and plan everything that we do. So for me, as a physician in this particular phase of human existence and in this particular culture, I was burned out. Come 2014, I didn't know what to do. I mean, I had built an inpatient palliative care program where I live in Humboldt County. And from the minute I started, there was 4, 5, 6 times as much as I could do. I couldn't scare up the resources for a stapler or a small office, let alone nurses, social workers, chaplains, and frankly, whatever you want to call them, teammates. This work is not done well by yourself, right? So I had it. I'd made presentations, I'd sat in committee meetings, I'd even written grants, and but I had to be a social worker, a chaplain, a nurse, and a doctor, and an administrator, and I had to beg and cower for the resources required to save the hospital millions of freaking dollars and to save the community at least some avoidable suffering, right? So I was sick of it and done. So in early 2014, I went looking for jobs down the road. I applied for 3 jobs in 3 weeks, got 3 offers, and then I kept driving home to my amazing community, my house, the place where I was married on the front lawn, Julie, where my daughter, Bella, and my son, Max, were born, upstairs, where all my pets are buried in the front yard. And I just didn't want to leave. So I had 3 breadcrumbs that I gathered up. One was I noticed that little smartphone thing that Liz was talking about. I noticed it in my pocket, and I was like, wow, maybe this is a tool for connection, duh. And maybe it has something to do with what's possible in doing palliative care. Idea number 1. Idea number 2 is something called Project Echo. How many of you have some knowledge or exposure, or that's another talk. Project Echo is simply a way of using a video conferencing platform to connect scarce expert resources, to share their expertise widely to community clinic structures. So for me, it was an idea about how might I clone or multiply my knowledge or impact by giving it away. And then the third thing was there was a friend of mine that had a graphics studio who crowdfunded a large format printer for her office. I had this crazy idea that, wow, maybe there's some way that I could build a team, a palliative care team for my community, and fund it with a crowdfunding campaign and not have to leave my house or my town where there's, at that time, I guess there was probably 2,000 ghosts floating around wherever I'd go. Every neighborhood I go down, I remember that street. I remember that home visit. I remember those people. I end up in the grocery store either being exposed, every time I go in, either there's somebody who comes up to me to say thank you, or somebody that goes like hiding in the toilet paper roll because they can't deal with me. Either way, it's soul for me. And so then I sent a little email to a friend named Kathleen Kerr, and I said, hey, Kathleen, I've got a crazy set of ideas. What am I going to do? Is it possible? What do you think? She said, well, I'm busy, but you've got to meet that guy right there, and he's going to tell you more about the job, but I'm going to say that Steve Franey has been my brother, my partner from the very beginning, and without him, we would not have created anything. He's going to tell you about and describe for you in some reasonable, practical detail what we're doing at Resolution Care. But I said, Steve, can we do this? And he got out his little soulful spreadsheets and sorted it out. He said, yeah, it's doable. So I quit my job, gave them a contract for an independent medical directorship for the palliative care program, launched a crowdfunding campaign, and in January of 2015, we walked into an empty donated office space, myself and an administrative assistant. Her name is Leanne, and the minute she came in, she said, I'm changing my job title to office synergist. I'm like, perfect. It's a good first employee, so she's number 1. And just to give you a sense of what we've accomplished in 4 years is we're currently taking care of 200 people in Northern California. We have people, actual clinicians and boots on the ground, mostly in Eureka and Humboldt County, but some in Del Norte, all the way up by the Oregon border, a growing little crew in Shasta and Redding, and a really getting to be quite solid team in Ukiah, serving Mendocino. We're taking care of a couple of hundred people. We've got 35 employees. And I personally don't know how that was actually possible, but Steve will try to explain that to you. When life is being completed, who we are matters more than what we have. A black dog is family, a small home is freedom, and a star-filled sky makes more sense than a university hospital. No offense to the university hospital. These pictures were all taken by my partner, my artistic partner, Justin Maxon, who I'm just really grateful. So I'm not going to belabor a bunch of storytelling. I mean, I could do it all day long, but I really want to invite this to be a collaborative conversation. There's no me up here, the teacher, and you over there, the audience, right? We're all in this together, and we're all making it up every single day. And so I want to have that as a conversation. Leah's going to work with us to kind of facilitate some discussion. And I want you to start now to generate your curiosity about things, about this role of patient researcher or clinician-patient collaboration. Like, how crazy is that, right? Or any questions you might have about the work that we're doing. Mostly I'm going to defer all those kind of details to Steve and Kathleen when they make their presentation later. So showing up in addition to state-of-the-art medicine is what's called for in response to the lived experience for when your hat's too big and your shoes are too small. His name is Boots. He's a poet. We got him housed before he died. And I still have a box with about 100 loose leaf, crinkled up, torn pages of his life work. And before I'm dead, I'll put it all together and publish it and share it with y'all. There is no such thing as patient, and there's really no such thing as resolution, despite the fact that I call the business resolution care. There comes a moment when there's nothing around the corner. Hope appears when the waiting is over. And now you get to ask us questions. What do I do? Wait. You get the hard part, or you get the soft part? Yeah.
Hello. Okay.
All good?
Yeah.
Check.
Test.
We're not going to feedback if we...
No,
You're
I
not
think
doing
we're good.
feedback.
Okay, good.
You're not doing feedback.
Oh, these
Yeah,
are
yeah.
sophisticated
You meant
microphones.
microphones.
Sophisticated
Yeah.
microphones. Okay.
All right.
So, as you can imagine, this was a pretty fun session to put together. We had a couple of conference calls, and honestly, the dialogue went everywhere. You should see my notes from these conference calls. I was supposed to have some questions already, but honestly, the notes were sort of so wonderfully out there and creative. I just thought, well, let me just see how the day unfolds, and so here we are. So, in order to get sort of our conversation started, and as you see, there's microphones around, so we invite you to please chat with these two because they're incredible people. We just thought maybe we'd ask, or I'd start off with a couple of questions, and then hopefully you all will jump in and help as well. So good, we've got some folks out there. So Liz, at the very beginning, you said something that all patients are researchers, for better or worse. I wondered if you could talk to us a little bit about that for better or worse idea.
Well, I think when I say all patients are researchers, clinicians go, that means going online. And I don't know if any of you have ever seen this meme. Some people are already nodding their heads. It says, "Don't confuse your Google search with my medical degree." Have you seen that? I mean, that's just so... You went to medical school. I did not. And many of you, you've gone through your training. I cannot provide the care that you provide. But just to say, like, if you're to take a curious person who's going through a serious illness and say, you can't learn anything to the level that I can learn. I think there's a lot of folks, when I say all patients are researchers, kind of have that instinctual response, like, what do you mean? And so I say, for better, for worse, to acknowledge to the audience, like, you might be thinking, what do you mean by this? But to say, I'm going to get there, I'm going to get there. And so there's much to be said for a person's lived experience and what they're going through. And so that's what I mean by the for better, for worse. I'm kind of preempting the question to the response, the hackles that might be brought up in some folks. That's what I mean by that. Yeah.
Yeah, I just want to add to that. Like, when I started medical school, one of the orienting kind of old professors said something to the effect of, like, well, we're about to teach you a lot, and we know that you're going to forget 50% of everything we teach you. We just don't know which 50% that is. And I actually think that estimate is a little bit generous. I actually think the future of intellectual management of all of that knowledge and radically complex and changing and accumulating information will be better done by gizmos and AI. And my hope is, what that means is that everything we've always been in healing will start to return to the center of what it means to be a physician, to be a nurse, when we have some help from the gizmos we've created to manage the information that we've created, that nobody can claim to be an expert in anything but some little teeny weeny bit.
I already want to respond to you. She talks about how we did some phone calls to prepare, and we're like, blah, 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 blah. She's like, when can I get the questions in? So today I talked about a project I'm doing as a person, a patient who's a friend of other patients. And this actually isn't my regular job. This is just a thing I do for fun. But my regular job is, which Leah alluded to, so I work for Beth Israel Deaconess Medical Center in Boston on a research project called Open Notes, and from the communication side, and I could talk about that forever. And Open Notes is about the concept of giving patients easy access to their doctor's notes after the visit, after the note is written. Right now, most folks have to go to the medical records office, and, like, if they even know doctors write notes. And again, that's a whole other presentation. Did my microphone go out? Okay. And so when you said, when you started medical school and Professor so-and-so says, you're going to forget 50% of what you've learned, it makes me think of, at most, people remember 70% of what happened in a clinical visit. At most, when they're feeling okay. But if somebody's getting bad news, studies show, people may retain 30%, up to 30% of what was being delivered. So if you're being told, Michael, you have cancer, and let's talk about all this wild stuff, you immediately blank out. And so if physicians are only remember 50% of what they learned, just think about what patients can remember and retain and learn. So.
I guess what they do remember, though, 100% of the hubris and status and privilege, that they remember that. They get that. They get that they're special, they're important, they're smarter than everybody else, and they're entitled to more control and power over the systems of which they're a part. They pretty much remember that. Now, they might manage it. I hope I'm learning to manage that.
So that's actually one of the poems or one of the quotes that you had on there struck me. You said, or one of your people may have said this in the picture, about building this infrastructure to care for people who care for people. And that's who's in the room here for the most part. I'm actually not sure if there are patients and caregivers in the room. Now that I think about it, I don't know that we asked that question. Thank you. Any things that you've been learning about how to build an infrastructure for the caregivers who care for the people that you want us to make sure to walk away knowing today?
Well, we're just beginning really to learn. This is a really new set of ideas, like to do video conferencing work to people in their homes changes the whole dynamic of engagement. So on the one very obvious thing, we're not taking a person who's managing or navigating a serious illness and dragging them into the healthcare center and the clinic in order to improve their quality of life. That's a little kind of counterproductive. So they get to save the sitting there in the waiting room with the 10-year-old People magazine and the chatty front desk people who are talking about things that are important to them. They get to save all the transport. They get to save all the half day of driving that their daughter has to take work off for. Most often it's a daughter. They get to save the stress of being plunked into a windowless room, mostly, and to deal with a doctor who's doing this and asking questions and managing their own agenda to get through the box clicks that measure their value to a certain point of view. So they don't have to do all that, but the other part of it is too, is that you actually put a beautiful frame around the encounter. Like literally, you put a frame around the encounter, and then within that frame, that you're in your place of reasonable comfort, my studio, my office, my home, if that's where I'm working from, and so are they. And all they had to do to connect with you was to click on a hyperlink. Click, poof, there you are. And if you leave them waiting a little longer, they're sitting on their couch having tea with their cat on their lap, right? They worry that maybe we forgot them, so they'll call after about 3 or 5 minutes if I can't get to it. But they're way more forgiving than the people who are stuck in those windowless boxes, stressed out for even 5 or 10 extra minutes. It seems like an hour when you're in there perseverating about what's wrong with you, because that's the whole frame. I'm there because there's something wrong with me. When you're in your home, you may have some challenges and issues, but you're a person in your own home.
Have any of you ever experienced a telemedicine visit where you're the patient? I was sick on Christmas Day. I got, well, you think it's food poisoning. I think it was gastroenteritis. But anyway.
Brett was sick too.
Yeah, and my husband was sick too. Okay. And sick Christmas Day, this is not a palliative care story. It's just like I'm throwing up all, I woke up 1 a.m. Christmas, blah, and like you can't get in to see a visit. And so I saw on the UC Davis website, they had a link like, we have this telemedicine thing. And having worked with Michael and learning more about telemedicine, I thought I'll give it a try. It was outside of my insurance network, but it was still $40. It's Christmas, I'll do it. And it was awesome because I was like totally destroyed on the couch with the computer, and I got the care I needed right away. And they sent in, this is totally a random side story.
Yeah,
but if you ever
totally
try it out, like experience it through the eyes of your patient, I'm sure. So, yeah.
So I don't know, did I answer the question or did I just wander off?
I think you did your regular thing.
We meandered.
Let's bring the audience in now.
Yeah, let's do that.
Yeah. And then
How would that work for low-income seniors and homeless, who don't have the cat on the lap?
With great effort and difficulty. However, what I can say is that, where's Barb? There you are. Hey, Barb. Barb is a partner. She works with Partnership Health Plan, a Medi-Cal managed care organization for 14 of the northernmost counties in California. And Barb and Jim Cotter, the medical director of the program, and Bob Moore, the CMO of Partnership Health Plan, have been the most valuable partners we've had. So the large majority of all the people we've seen over these 4 years have come to us with a benefit from Partnership Health Plan that says, hey, these people are sick enough that they actually need to get a doctor, a nurse, a social worker, a chaplain, a community health worker, wrapping around them wherever they live to mitigate their suffering, to settle them down so they can navigate and join them in navigating the health system. And oh, by the way, it's not the primary driver, but they're saving $3 for every $1 they spend. So they're all about it. And of our 200 or so patients under care right now, 140 of those people are poor and young and highly burdened by the complexities of the social determinants of health. They're mentally ill, they're substance using, they're homeless, and we've got this wraparound service to do it. So many of those people we assist in getting a home. Some of those people we offer them technology, connectivity. We lend that to them. We've got a few, we've got like 20 or 30 at this point. We do what we can, but it's a lot of heavy lifting, but it's good work if you can get it. So with the elderly population, we're really kind of hamstrung. We don't, even with complicated strategies for appropriately billing Medicare patients, we can't get barely to a third of our costs by doing it for now, with the hope that in 2020, 2021, maybe we'll get a chance to be a demonstration project for CMS to take this kind of unique way of, we'll pay you this much money per month to do everything you can think of to make this person's life better. Maybe we'll get that opportunity to do that with our elders.
So you're not rich right now?
So Liz, this question is for you. And first of all, Michael, I want to tell you, I totally get how you fell in love with this lady. She's amazing.
Right.
But I had
Like
a
a
cousin who died from your disease. And I really want to know why you're alive.
Oh.
Is it that you totally connected with the soul?
Man.
I mean, I understand medical issues.
Yeah. I lucky. Okay, so wow. Okay, I can get really nerdy with you. So when I was diagnosed, 2008, there's glioma, so tumors of the glial cells, and they were graded under a microscope. So they're like, here's a piece of your brain, look at it under a microscope. Depending on the way it looks, there's pathology. We grade it 1, 2, 3, 4, 4 being the most malignant. And my diagnosis was grade 2, and actually it was like on this border anyway. And then grew back, looked at the same tissue after surgery under a microscope, and it's like this 2-ish, 3-ish, but you're young, so we're going to treat you only with chemotherapy and not do radiation yet, because who knows the long-term side effects of this brain radiation, and we hope you live this long life, and if it comes back a third time, which it statistically will, then we could do radiation, whatever. So 2008. In 2016, the World Health Organization came out with a new classification for central nervous system tumors. And there's a whole bunch of cool, fancy new science that's happened where they now look at this tissue. And in addition to looking under slides for pathology and grading, then there's biomarkers and fancy stuff looking at the DNA of the tissue. So it's not just pathology. And there is no such thing as a grade 2 being better than a grade 3, well, kind of. But it's much more than that. So then they're looking at biomarkers. And so I have these, so even though I haven't had surgery recently, I contacted my doctor and said, can I find out what my biomarkers are? Like now that anyone diagnosed today, you send it off for pathology or this special biomarker review. Could I do that? My doctor said, well, you could, but why would you want to know that? Well, I'm me. I'm looking at the latest information out there, and I would want to know what those biomarkers are, because looking up grade 2 astrocytoma is not the same as grade 2 astrocytomas plus all these biomarkers. Like, how can I stay up to date? He's like, okay, fine. No, actually, he said, wait. Once you know something, you can't unknow something. I was like, well, anyone diagnosed today would get the full picture, so I would like my full picture. Okay, long story short, we finally sent out the slide. It's sitting in the library somewhere. And find out I have the IDH1 mutation and this ATRX negative, these fancy biomarkers, which essentially show this new clear picture that if other people with my same pathology, and we compare us all, I have a more favorable prognosis than those with different biomarkers. So we might all be grade 2 astrocytomas. He might not have this mutation. She has these other extra mutations. It's just, we're now different. We're more these unique, weird snowflakes. And there's different ways to treat. Do you treat more aggressively? Do you, you hold back a little bit? And so I would say, medically speaking, I have a more favorable prognosis when you look at all of the details. So that's why I'm still alive. Yes. I love palliative care. Like, how are you feeling? There's everyone, responds to these things in different ways. And I think I said, I really dug down. I was like, why did I respond this way? That whole curiosity aspect. And I don't come from a medical background. I don't even have a bachelor's degree. I have a graphic design degree from Sacramento City College. Woo! And so it's like, how does like a person with only so much level of education understand really and get into this? And I'd say, you can't just judge people based off of what is the level of education of this patient. Let's take their social status and what do they do. You never know the capacity for people to get into this stuff. And we have so much access to more information. People are looking stuff up. And I was trying to figure out recently, like, who people talk about teachers who changed their lives. Like, if it wasn't for Mrs. So-and-so in second grade, I wouldn't have X, Y, and Z. And I think the doctor who had the biggest impact on me at the very moment really of diagnosis is this guy who I got to send him a letter. His name's Paul Akins, and he's a neurohospitalist at Kaiser and Morse Avenue. I'm going to track him down. I just got his email this week. And I remember being after brain surgery 1 in neuro ICU, and I'm on my computer looking at TED Talks, and he goes, if you like TED Talks, you should look up the TED Talk by Dr. Jill Bolte Taylor, who's a neuroscientist who had a stroke, who then recovered and wrote this whole book from her perspective of a neuroscientist having a stroke. And Dr. Bolte Taylor, as she was having the stroke, she said, this is so cool. I finally get to experience that. And I saw the TED Talk and I was like, yes, this is cool and weird. And I didn't internalize like a brain tumor was my fault. I thought, what a fascinating experience. So then I read her book. And then I emailed Dr. Akins and I said, thank you so much for recommending the TED Talk. I read the book. He's like, well, if you like that, you should look up Oliver Sacks, this famous neurologist who's read The Man Who Mistook His Wife for the Hat and da-da-da-da-da. So then I went on this Oliver Sacks tear. And then I said, I've just read 5 Oliver Sacks books. What do you recommend next? He's like, well, as a designer, you're going to be interested in learning more about the occipital lobe and how we perceive things and vision. And so then he's like, you should read this medical textbook. And I read like 3 pages. I was like, I don't know if I'm going to get this. But he encouraged me to learn more and curiosity and keep going. And I think he has no idea. And so I got to write him this email. But if it wasn't for him not, you shouldn't read that, you shouldn't look into it, he just kept it going. He's feeding it. A teacher,
he
really.
He could be watching.
He could be, really. He's not. Yeah.
Oh, I just want to comment, Liz, you are a remarkable woman and a unique patient. As I listened to you, I'm like, okay, I graduated UC Davis residency over 20 years ago when the internet came out. When I was brand new clinician, I had a older gentleman, who was into the internet. I didn't even know what that was at first. And he told me, doctor, I have this disease because I have all these symptoms. And I hadn't even heard of this disease. I looked it up in my Harrison's book that looks like a Bible. And then I realized, sir, have you been to Africa? No. Are you a descendant of African? He's a Caucasian guy. And I said, this disease actually only happens in Africans. And though you have the symptoms, your diagnosing is wrong. And so in 20 plus years, I get a lot of patients who are, curious. I think the difference between you and a lot of patients, and I was talking to some colleagues here, is you're curious and you're honestly curious and you want to learn, but that's what makes you unique. I think cynically from my standpoint, from my experiences, a lot of patients, what we always say, a little information is dangerous. And then they start self-diagnosing, and then it's just, then I start getting it, I have to explain or get into a debate why they don't have this disease. And then it just becomes a bad doctor-patient relationship. But I have to say, is you're giving me faith to at least ponder talking to millennials who are inquisitive. And I want to thank you for that, because I'm trying to get rid of my cynicism. But at the same time, you are not representative of most patients, and I think most providers here can agree. You're like a sponge, is my opinion, which is wonderful. And I think your personality, your spirituality, whatever, your soul, I like this woman implied, I think you recovered because you were so special and in tune with yourself. I don't think a lot of people, unfortunately, I don't think a lot of people are, but my wife is a psychologist and she's getting me into this mindset, like you guys, about non-medicinal, focus on the other issues. And I think that's, I just want to thank you for that, but also want to be the cynical doctor reality check that you're unique. That's all.
Can I respond?
Yeah,
I'll try to make it. Thank you for that. I empathize, or I hear that. I've heard that. You know, you're special from a perspective of not all patients are like you, kind of a thing. And I actually, as a person who's now been living with disease and hanging out with other patients and on these Facebook groups where I'm seeing patients saying, I think I have a brain tumor because I have headaches 10 times a day. And I want to be like, well, there's so much more to, like, I'm starting to get that cynical perspective. But I think it doesn't have to be, I think there's so much potential to, if your patient comes in and it's like, oh, I think all these things, and you're like, well, we need to change the dynamic around. Perhaps there's an opportunity for the clinician to be in a teacher role, as opposed to we're only allowed. You individual patients don't have access to all the information. You know, there's all of the cool stuff is in these medical journals that are on these paywalls that are behind. A lot of information is held back from patients. And so we're at this opportunity where patients are changing, a little bit of medicine is changing, and those dynamics of who knows what and how we present information to patients is in a state of flux. And it's not there yet. It's not perfect. It's not pretty. But I'm optimistic that there might be a change in culture in time. I think Michael's going to say something.
Yeah, I want to say something. So just as a show of hands, who in the room thinks they know more about brain cancer than Liz?
Yes.
Now, Liz, how much do you know about Sjogren's syndrome? And so, how much do you know about everybody's brain cancer compared to how much you know about your own?
A bit.
You know a bit,
yeah,
but less than what you know about your own through the lens
of... If it's a glioma, I know a lot. If it's an oligodendroglioma, a little bit. But and if it's a non-malignant brain tumor, less. But I know the symptoms and side effects are very similar.
But there's a sort of a peak of knowledge that focuses on where you are on the spectrum of possibilities. Understanding how to integrate the complexity of all of that science with the subtlety and complexity of all of this life is a collaboration, right? Like, I'm not an expert in glioblastomas, but I've been helpful as an advisor and friend and co-explorer to understand what it means to have a glioblastoma. And I hope that I've been useful. Yeah?
I'll let you finish.
Go ahead. I'll be finished. Because you're going to say something
and it's
nice.
Interesting when you said, how much do you know? I'm like, oh my God, I know so much. I just went to the Society of Neuro-Oncology conference and it was awesome. Like, I know so much because I'm the person I have this lived experience. Yeah. None of us are neuro-oncologists. Right. We don't know as much as neuro-oncologists, but I know a lot about brain tumors and brain cancers. Right. But in that video, which was, the video and the camera in the car, we were at a stoplight, by the way, it was safe. When I sent that, it was before you decided to join me on the project, the Brain Cancer Quality of Life Collaborative. And out of all of the stuff I know about brain tumors and brain cancers and the neuro-oncologists I've spoke with and the cool stuff I've been reading that's open access journals, not a single person ever talked to me about death and dying. Now, I remember asking my neuro-oncologist, 5 years out, doing well, hey, how come we haven't talked about palliative care? How come you haven't asked me lately about my advanced directive? Because I've updated it and I put it online, by the way. And he's like, well, you don't need that right now. I'm like, but maybe now is a good time. Like, I'm not freaking out. Like, we should talk about this stuff. And no one has told me how that works. Like, how could I have so much information about brain tumor stuff and not an understanding of how people die with this disease?
Right.
Is this it? And how much more time do we have? Let's check in.
11:51.
Another 5 minutes. I know Dr. Duncan Lael up there in the corner had a...
Oh, okay.
Hi, thank you so much. I'm such a big fan of all of you. I just want to thank everyone for their comments, and then also weave a couple of thoughts together. I'm obviously a little bit older than some of the folks in the room here, and also came out from medical school when there was no internet. And as an infectious disease specialist, practicing in 1990, you know, my patients had hepatitis and HIV. And even without the internet, let me tell you, there was a net. These folks would come into my office with tomes and books of paper and everything from every, every kind of integrative type of healing that we now see today, and completely unheard of back at that time. Milk thistle and kava root and, just amazing things. And so there have always been, as much as I admire you, Liz, you're not the first curious patient. and I was like the other gentleman here, I was quite taken aback and felt, challenged and insecure because I didn't know about milk thistle at the time yet. And there wasn't actually any place for me to go to learn about milk thistle. So I had to learn about it with them from their networks and then try to understand the toxicity. And that was a real growth and experience for me, but it really showed me at a kind of a young doctor age the importance of the provider-patient partnership and how that could work for or against you depending on your own response and depending on the type of the patient. And just leap forward, not that I was able to sufficiently integrate that into my care during the years that the healthcare system in general just completely beat the love out of me. But jump ahead now to what I have been doing and teaching and educating about this, how to communicate about palliative care and advanced care planning, and really want to just point out that what Dr. Steinhorn was saying, what you guys are saying about that, not just trauma-informed care, but informed care. Every single person is a complete individual. They are their own resources of expertise. And unless we inquire of them how they want to manage their own healthcare and how they want to be involved in the care process and whether or not they want high-level information, mid-level information, or maybe no information, then we do not know and we cannot engage with them. So we really do have to ask. And even those of us who are scientists, when they are suddenly wearing the paper gown, I didn't want to know. When I was diagnosed with breast cancer, and Liz was around at the time, my mom had died at 51 from breast cancer. I was diagnosed at age 50. I didn't want to know. I almost didn't want to know the cell type. I'm like, well, this is going to work out or it's not. And it's probably just, okay if I just don't know all the nitty-gritty details, because I felt like with my scientific brain, I kept trying to second guess everything. And it wasn't really in my best interest. And so I had to pull back, which is a little bit different from what Liz was doing at the time. So we each find our own way. But without that communication, we don't know what the other person might be needing or thinking. And I think we go back and forth. Like there are some days when, I want to know all about my cell type because it's a little different from, and maybe there's something new. And then there are other days when I'm just up to here, and could I please just not get any more tweets about that right now? So again, it comes down to having really rich and very, very open conversations, which is quite different than what we have done in the past with our patients. And yes, it is time consuming, and it doesn't matter. We have to find ways to do it. And we have to do it with skill and humility and extreme efficiency. And we have to do it every time.
And if it's not the patient who wants to know everything, there's somebody caring
There's
for that
somebody
person.
else who does.
It is their care partner, their spouse,
The whole circle.
their child, or their
Yes.
I'm thinking we may need to call time. We've had a great session here. I'm going to reinterpret one of the slides that Michael had up there front, the WTF. Where's the finish? And so I think we're kind of at the finish, but I hope you'll be around during the breaks for folks to talk to, and really appreciate all the wonderful dialogue, and thank you for being here today.
Thank you. Thank you.